Bismillahirrahmanirrahim. Uh, my name is Ahmed Darwish, Associate Professor of Pediatric Hematology, Oncology, and Bone Marrow Transplantation. Today I'm going to speak about oncologic emergencies in pediatrics. It's well known that more than 40% of pediatric oncology patients may be in need for a pediatric ICU during their care. We can classify pediatric oncologic emergencies into four groups. The first group is a metabolic emergencies, and metabolic emergencies have got the most common one, which is tumor lysis syndrome. The second oncologic emergency is infectious emergencies. The infectious emergencies include mainly septic shock and neutropenia, of course. And the third is hematologic, which is mainly hyperleukocytosis together with agranulocytosis. And lastly, we have the mechanical, which could be mediastinal mass or herniation of the brain or even compression of the spinal cord or an abdominal mass leading to intestinal obstruction and so on. Let's start with metabolic emergencies. First of all, the tumor lysis syndrome. The tumor lysis syndrome usually results from the breakdown of a large tumor. Whenever a large tumor is broken down, the cells will release their intracellular contents, including the nucleic acid, which will be converted later into uric acid, leading to hyperuricemia, and increase in the serum phosphorus, which will lead later to decrease in the serum calcium, and increase in the serum potassium. Usually, tumor lysis syndrome occurs after giving chemotherapy, especially to the highly sensitive tumors to chemotherapy. But spontaneous tumor lysis syndrome may occur in some patients with those tumors which are rapidly growing, like in Burkitt's lymphoma, for example. If we just look for the laboratory tumor lysis syndrome, whenever we want to diagnose tumor lysis syndrome, we have to diagnose the lab. In order to diagnose the lab tumor lysis syndrome, we have at least two of these features. And this could occur 3 days before or 7 days after initiation of chemotherapy. Number one, hyperuricemia, uric acid level more than or equal to 8, or an increment of more than 25% from the baseline, or a potassium level of more than 6 milliequivalent per deciliter, or 25% increase from baseline, and serum phosphorus level more than or equal 6.5 milligram per deciliter, or an increment of 25% from the baseline, and calcium level which is low, less than 7 milligram per deciliter, or a decrease of calcium by about 25% from the baseline. Secondly, we can diagnose clinical tumor lysis syndrome. In order to diagnose tumor lysis syndrome, there must be at least laboratory tumor lysis syndrome with one of these three. Number one, a creatinine level more than 1.5 times the upper limit for the age, or sudden death or cardiac arrhythmia, or the presence of seizure. How can we evaluate a patient with tumor lysis syndrome? And what are the risk factors for tumor lysis syndrome? These risk factors include large tumor burden, rapidly growing tumors, of course if the patient have got hypovolemia, and of course if the kidney function is affected in renal insufficiency. Most of the tumor lysis syndrome occurs 6 hours to 72 hours after the start of chemotherapy, but I have said before it could happen spontaneously without starting of chemotherapy. As we mentioned that patients with tumor lysis syndrome are susceptible for electrolyte disturbance. Therefore, there must be a baseline blood chemistry, there must be a baseline for a CBC, for the renal function, and even for an ECG, because we know that, for example, hyperkalemia, hypocalcemia, these can lead to ECG changes. What about management of tumor lysis syndrome? For tumor lysis syndrome, actually, for tumor lysis syndrome, the patients should be admitted in the ICU, of course. It's better to admit them in the ICU, and it's better also to consult a nephrologist. And for better management of electrolyte disturbance, we must establish a good venous access, especially a central venous access. And of course, we should monitor frequently the serum sodium, potassium, calcium, uric acid, creatinine, urea, LDH, phosphate and bicarbonate, and others. And tumor lysis syndrome is best managed proactively. Why? Because we have to recognize the high-risk patients and we have to take measures to prevent it before happening. And what are these best measures to guard against tumor lysis syndrome? Of course, good hydration. And of course, we can do what we call alkalinization of urine by giving sodium bicarbonate, because this will neutralize the uric acid crystals, preventing them from precipitating in the kidney. Using allopurinol is also of value because, especially 2 or 3 days before starting chemotherapy, because allopurinol is known to decrease the amount of formation of uric acid. But what if the uric acid level is already high? We have to give what we call raspuricase, which is considered a urate oxidase. Can tell us how the nucleic acid is metabolized. Whenever a nucleic acid of purine, for example, is metabolized, it is converted into hypoxanthine. And this hypoxanthine is going to be converted into xanthine. And by xanthine oxidase, the xanthine is converted into uric acid. We all know that it's water insoluble and it's toxic. If we can just give allopurinol, it can inhibit the xanthine oxidase. So allopurinol can inhibit the xanthine oxidase, so prevent conversion of xanthine into uric acid. But what if the uric acid is already high? We can give what we call raspuricase, which acts as a uric oxidase stimulator, or a sensitive one, recombinant uric oxidase. So it can convert the uric acid into allantoin. So it can convert the water-insoluble product to a water-soluble product easily to be excreted. Of the effects and complications of tumor lysis syndrome, we can have hyperphosphatemia, which can lead to secondary hypocalcemia. So how can we deal with this situation? We have to give phosphate binders. Okay? And whenever the phosphate is very high, it's sometimes indication for dialysis. For hyperkalemia, we can treat hyperkalemia by giving calcium, because this will counteract the action of potassium on the heart. We can give sodium bicarbonate, insulin glucose, salbutamol by inhalation to do what we call intracellular shift of potassium, so it can decrease the level of potassium in the serum. And in order to decrease the amount of potassium, we can give what we call cation exchange resin, stilbostirate, for example, because this can decrease the amount of potassium which is absorbed and increase the amount of sodium absorption instead. That's why it's called cation exchange. But if refractory hyperkalemia and have got the ECG changes, we can do dialysis for the patients. This is regarding metabolic emergency tumor lysis syndrome. What about hematologic emergencies? Hyperleukocytosis is one of the most important hematologic emergencies. And hyperleukocytosis is defined as white blood cell count more than 100,000 cells. And of course, it could be present initially in patients with ALL, especially TLL, and AML sometimes, and CML some other times. Whenever white blood cells are very high in count, of course, it can lead to increase in the blood viscosity and some sort of leukostasis. And this can occlude the blood vessels, leading to some sort of endothelial damage, and of course, organ damage and tissue injury. Two of the most important organs to be affected with this leukostasis, we have the lungs and the CNS. The lungs can have some features of tachypnea, hypoxia, even cyanosis, and sometimes we have some interstitial infiltration in the chest X-ray. But what about the CNS? We can have some sort of encephalopathy, like the presence of altered or disturbed conscious level. We can have some sort of blurred vision, dizziness, headache, even seizures, and sometimes coma. And also management of this hyperleukocytosis can be done by good hydration. And of course, we have to reduce the tumor burden by other chemotherapy or leukapheresis. And we don't have any guidelines for initiation of leukapheresis. or exchange transfusion. But some experts recommend initiating leukapheresis if white blood cell count is more than 200,000. Of course, we have to do some supportive measure, especially for those they are at risk for tumor lysis syndrome. And better to avoid transfusions because this can increase the viscosity of blood. And platelets should be given if the patient has got some sort of bleeding. The second one is for hematologic emergency is neutropenia. Neutropenia is the most common toxic result of myelosuppressive chemotherapy. So chemotherapy, especially myelosuppressive chemotherapy, like doxorubicin, cyclophosphamide, and ifosfamide, these can lead to neutropenia. And neutropenia is one of the most toxic results of this chemotherapy. And an absolute neutrophilic count of less than 0.5 are associated with increased risk of infection, of course. And if persists of more than 2 weeks, it's usually associated with risk of opportunistic infection like systemic fungal infection. And usually, if this neutropenia is prolonged, we have to treat it using granulocyte colony stimulating factor. The third one is infectious and inflammatory emergencies. The first term is sepsis. How can we diagnose sepsis? Before diagnosing sepsis, we have to diagnose first SIRS, which is called systemic inflammatory response syndrome. To diagnose systemic inflammatory response syndrome, we must have at least 2 out of 4 items, including a temperature of more than 38.5 or less than 36, a tachycardia of more than 2 standard deviation for age, or bradycardia if less than 1 year. Number 3, having a respiratory rate of exceeding 2 standard deviation above the age, and a white blood cell count above or below normal for age, and of course not related to chemotherapy. What about sepsis? Sepsis means if we have SIRS in addition to a proven or suspected infection. What about severe sepsis? Sepsis is said to be severe if it is associated with cardiovascular dysfunction, respiratory distress syndrome, or more than or equal to 2 organ dysfunction like neurology, renal, hepatic, or hematologic. What about septic shock? We have septic shock if we have sepsis in addition to cardiovascular dysfunction, like the presence of hypotension, dependence on vasopressor agents, presence of metabolic acidosis, increase in lactate, oliguria, delayed capillary refill time, or a temperature gap of more than 3 degrees centigrade between core and peripheral temperature. How can we manage septic shock? Of course, early management is the best in the first golden hour. So early reversal of this shock has recently been shown to decrease the progression and decrease the progression towards the multiple organ dysfunction, and it will improve the outcome. Of course, time from diagnosis of septic shock to fluid resuscitation antibiotic administration is significantly associated with mortality rate. So whenever the time is running out, so time is very, very important in this issue. What about hemorrhagic cystitis? Hemorrhagic cystitis, it is hematuria which results from inflammation of the urinary bladder wall. And usually it's caused by a chemotherapy called alkylating agent like cyclophosphamide and ifosfamide. Okay? Because these therapeutic agents will lead to some sort of metabolites that will lead to chemical inflammation of the urinary bladder wall. We call it this hemorrhagic cystitis because it will lead to hematuria. One of the causes also for having hemorrhagic cystitis is the presence of previous or concurrent pelvic irradiation. Of course, the optimal treatment of these conditions starts with prophylaxis to decrease any contact, to minimize any contact between these dangerous metabolites and the bladder wall, bladder mucosa from inside. These primary prophylaxis include, of course, good hydration, hyperhydration, together with sometimes continuous benign bladder irrigation or we can give what we call Medecine. Once present, once hemorrhagic stents is present, it's best treated also with hyperhydration, continuous bladder irrigation, but we can give platelet transfusion and treatment of any coagulopathy which could be present. The third issue is extravasation. What do we mean by extravasation? It means extravasation of chemotherapeutic agent. This can lead to severe or irreversible local injury. Chemotherapeutic agents may be classified into either irritant, vesicant, or non-vesicant on the basis of their local toxicity to subcutaneous tissues. So extravasation of chemotherapy be can be very severe, leading to, as I could said, a reversible local injury. And these chemotherapeutic agents may be either irritant or could be vesicant or non-vesicant. Irritant drugs means that whenever extravasated, they can lead to some pain at the site of injection and maybe just associated with local inflammation at the site of extravasation. Non-vesicant drugs can produce some sort of acute reaction only occasionally. However, vesicant drugs are the most dangerous, leading to local tissue necrosis and even blister formation. Whenever a chemotherapy is extravasated, we should leave the intravenous access in place, even if it is outside the vein. And we have to aspirate the residual drug as possible as we can from the infiltrated area. Even we can inject an antidote if available, inject it into the site of extravasation to counteract the action of the toxic effect of the chemotherapeutic agent. And we have to avoid placing any direct pressure on the site. This could minimize the risk of spreading the agent, so this will decrease the area of necrosis. We can apply hot fomentation or cold fomentation as appropriate, depending on the type of chemotherapy, because some chemotherapeutic agents, whenever extravasated, we can just put warm fomentation, but if others, we can just give cold fomentation. Of course, we have to do some sort of daily evaluation of the affected area and to do a consultation for plastic surgeon if necessary. The last emergency we are going to speak about is mechanical emergency. Of course, we have 4 types of mechanical emergencies, including obstruction of the airway, compression of the spinal cord, increase of the intracranial pressure leading to brain herniation, and sometimes GIT obstruction, spinal obstruction, I mean. Although mediastinal tumors are rare in pediatrics, however, whenever they are present, they are associated with significant morbidity and mortality. Therefore, rapid decision making is very important because it's life-threatening if they are large in volume, leading to upper airway obstruction and compressing large vessels, especially superior vena cava, leading to what we call superior vena cava syndrome. It could be either anterior, which can have lymphoma or teratoma, or middle mediastinum having lymphoma, or posterior mediastinum having neuroblastoma. And clinically, mediastinal masses could be presented with a lot of manifestation, but this depends on the site of involvement and the size of the tumor. So we can have some symptoms of chronic illness like chronic cough, fever, weight loss, and sometimes back pain. We can have also respiratory distress if the lumen of the respiratory system is decreased by more than 50%, and we can have some sort of tachypnea, wheezes, stridor, and we can have some sort of superior vena cava syndrome. Okay, and this superior vena cava syndrome means that the patient is high risk for respiratory failure and respiratory arrest. The superior vena cava syndrome include some features like face swelling and neck swelling, a prominence of chest veins and neck veins, presence of cyanosis or plethora, stridor, dyspnea, and sometimes hyperextension of the neck and chest pain, and sometimes respiratory arrest. Is a chest X-ray for a huge mediastinal mass that can lead to superior vena cava syndrome. What about the spinal cord compression? A compression most commonly occurs because of either direct extension of metastasis in the vertebral bone, but it also may result from the growth of a tumor through the intervertebral foramina. So it could be a metastasis or a tumor originating inside that vertebral foramen. The first symptom of spinal cord compression is pain, and this pain is associated with epidural compression of the spinal cord. And what is very important is to know that this pain is usually exacerbated whenever the patient is in the recumbent position, but it will improve when the patient is in an upright position. Secondly, the patient may suffer from weakness, okay, but usually affection, the motor affection or weakness usually follows the presence of pain. The last thing to be lost is a sensation, so sensory complaint usually follows after the weakness. Of course, MRI spine is the best diagnostic test to localize the disease and to distinguish any tumor or any abscess or any hematoma or even disc herniation. And if there is a spinal cord compression, of course, rapid intervention is very important to minimize any irreversible dysfunction. And how can we treat these conditions? By just giving analgesia, steroids, sometimes radiation, and sometimes surgery by doing what we call decompressive laminectomy. The last thing is the cerebral herniation. Cerebral herniation or increased intracranial pressure may result from a mass expanding in the cranial vault, or even from an obstruction to the CSF circulation. Either process may be due to a tumor mass, or a hemorrhage, or a thrombosis, or abscess, or even infection. And we have some sort of classic clinical findings suggesting impending herniation, cerebral herniation, like the presence of disturbed level of consciousness, abnormal extraocular movements, abnormal pupil size, nausea, vomiting, neck stiffness, papillary edema, or even having a Cushing reflex like hypertension and bradycardia, because these are late signs of increased intracranial pressure. Of course, MRI is the best for neuroimaging, and many told it is the agent that most frequently used to lower the intracranial pressure. And of course, don't forget that dexamethasone can just help to decrease the intracranial pressure due to tumors or abscess.